Thank you guys all for coming. My topic for the in-service is focusing on the movement system impairments and specifically different knee diagnoses that are given to patients. I obviously go to Washington University in St. Louis, so everything talked about here is stuff that I have learned at school. So before I get too much into it, I'm basically going to go through the seven different knee diagnoses that we give patients. I'm going to talk about what the diagnosis is, where the patient might have pain, what types of patients might have pain with this specific diagnosis, and then I'm going to talk about different things you might see in that patient's alignment. From there, I'll talk about key tests that you might do for that patient. Really good. Okay. Key tests that you might do for that patient to determine if they have that specific diagnosis. We'll talk about functional activities and how you can cue the patient specifically, and then I'll talk about some exercises that would also be good for that patient. So to start off, the most common one that is typically seen is tibiofemoral rotation. That's just impairment of the tibiofemoral joint. Typically, you're going to see that with valgus or varus. It just depends. And then you're going to find pain around the patella. For that patient, it's usually going to be athletes that have that lateral rotation. So maybe it's soccer players, they're laterally rotating the tibia. Ballet dancers are common. Horseback riding, maybe even swimmers or skaters, anyone who's getting that tibial rotation laterally. The typical alignment is going to be medial femoral rotation and then the tibial lateral rotation. So they're getting a lot of that rotation at the knee joint, and that's going to be causing them pain. So key tests you would do, I really like doing the squat, like a partial squat with these patients, because you can immediately see the adduction and the medial rotation of the femurs, and at the same time you could see either lateral rotation or even neutral stance of the tibia, but they're going to be getting a lot of rotation at the knee, and that's probably going to be causing them the pain. You can also look in single leg stance. You'll see, again, medial rotation of the femur on the tibia, and then you can even get them in prone or in supine. In supine, if you look at the hip flexor length test, I don't do this one enough, but as you lower the leg down to the table, you'll see that tibia start to rotate laterally. So that'll be a cue that that patient's getting too much lateral rotation of the tibia on the femur. If you put them in prone, you may see excessive tibial movement on the femur as you flex it or as you medially and laterally rotate the leg. As you flex them up, you might see more lateral rotation of the tibia. So they may be in neutral if they're extended, but then as the knees flex, the tibia might kind of turn a little bit laterally. And then in gait, the same thing. In stance, you'll see that medial rotation of the femur, and then in swing, you might even see lateral rotation of the tibia. So you're really looking at what's happening with the femur on top of the tibia, and if they're moving together, or if you're getting too much of a rotational force at the knee. So in functional activities, you're going to cue them to try to use the glutes a little bit more, just in general. So in walking, when they're putting weight on the leg in stance, you want them to use the glutes. For sitting to standing, you want to cue that their knees should be over their feet, so they're not getting any of that femoral medial rotation. That way they can get the glutes to work a little bit more. We also want to get that weight shift forward to get the glutes working a bit. With stairs, again, as they're putting weight on that foot, you want to make sure they're avoiding that internal rotation of the tibia on the femur. And then with sitting, you want them to avoid crossing their legs, which can be really hard for patients, but if they're getting that leg crossing, they're probably getting femoral medial rotation, and then that's stretching out their glutes as well. So we're trying to kind of do the opposite and shorten those glute muscles a bit. So key exercises that you want to work on in the clinic with these patients. We want to strengthen the glute med, the glute max. We want to try to stretch the TFL because that could be giving them too much femoral medial rotation. You want to stretch the hamstrings and the gastrocs, and then we'll look at functional things as well. So different ideas for strengthening the lateral rotators and glute med. You could do clamshells. You could be doing just side stepping, hip abduction. All of those are good. Glute max, the big one that I put here is prone hip extension with the knee flexed. You could also do squats, lunges, things like that. To stretch that TFL, you can put them in prone and work on getting more adduction of the femurs instead of abduction, and that'll help stretch the TFL. For hamstrings and gastrocs, you could do supine with the leg extended that way, or if they can't tolerate that, you can do sitting for the hamstring and then getting that dorsiflexion for the gastrocs. And then functionally, because so much of their life is spent doing their functional activities, kind of just giving them our exercises may not be enough. We want to make sure that they're educated enough so they're paying attention when they're going from sit to stand, when they're doing steps, all of these different activities, they're paying attention to where their knee is in position with their foot. So we want to work on, getting them in line so they're not getting that excessive rotational component. Okay, so the second most common knee diagnosis is knee hyperextension. As we can see in that picture on the top, the right side is going to be the patient that's a little more normal. That left is kind of excessive hyperextension, so you almost see bowing of the tibia, kind of looks like. So this is when a patient has too much hamstring dominance, and that puts a lot of stress on the structures inside of the knee joint. You're going to see that a lot with patients that are swimmers or dancers, people speed walking, people who have to do a lot of kicking like martial arts. When they're getting that rapid knee extension, it's just going to kind of make the knee more lax, and those ligaments aren't going to be able to work as well, but also they're just going to continue to use those ligaments and not use the muscles as much. Typically they have pain behind the knee or around the knee. Can even also be that joint line. With these patients, again, you'll see those locked out knees. It might go with their like a sway back posture and a posterior pelvic tilt. Not always, but that's kind of a pattern that can be common to see. Okay. So the tests that you want to do with this patient is looking at a lot of things just with weight bearing on that leg. So it could be stepping up. You're going to see that knee locking back. It could be standing on one leg. Again, you're going to see just like extreme hyperextension. There's not any flex to that knee. It's just locked out, and they're not really using any of those muscles to hold themselves up. You can also get them in prone and look at prone hip and knee extension. You'll see really dominant hamstrings because they're basically not using their glutes. Their hamstrings are just really strong. And sometimes they have a really hard time learning how to activate those glutes better, and they just want to use their hamstrings. And then with gait, again, you'll see with every step they're kind of snapping back that knee. So the picture at the bottom is pretty excessive, but it's just showing a patient that really doesn't even get a lot of knee flexion as they're walking. They're pretty much just staying in complete extension. They go into that very rapid hyperextension when they're weight bearing all on that right leg. So this is kind of extreme, but that could be what a patient looks like when they're walking for you in the clinic. So cues you want to give them with gait. We want them to unlock those knees. The ways we can do that is getting them to land with a softer heel, working on getting that heel toe, and then when they're getting to the end, we can have them lift the heel a little bit earlier. So instead of getting their leg back here where it's snapped back, we can get them to kind of step and unlock a little bit by lifting the heel early. With sitting to standing, we want to make sure that as they're standing, they're not snapping the knees back and pushing into that chair, because we want them to use the muscles a little bit more, but also that we can use that chair to kind of teach them, okay, as you stand up, make sure your knees aren't hitting it. We want them to just remain soft at the end of the standing up. We also want to get them to work on their knees extending at the same speed that their hips extend. So a lot of times they'll want to extend their knees and then their hips, but if we can get them to kind of do them together, we may get the glutes to activate better, and it may not all be coming from the knees snapping back. With stairs, again, because they're alternating steps, you're going to see as they put their foot on the step, it locks every time they alternate. So just getting them to walk with like softer steps, that can help get their glutes and their quads working better and working more than just using those ligaments. And then if they're standing for a long time, we want to make sure that these patients know that they need to stand with those knees unlocked. So I like to use the cue, imagine you're in a room that's 1 inch shorter than you, and you kind of have to stay below it or you're going to hit your head on the ceiling, and that works with some patients to be like, okay, I need to just keep that slight unlock to my knees at all times. So good exercises. Education, super important. Why are we getting them to unlock their knees? We want them to use the muscles more than just stretching out some of those ligaments, hopefully therefore decreasing their pain. We want to strengthen the glute max and the quads. We can use that prone hip and knee prone hip extension with knee flexion to get some of the glutes. We can also do lunges and squats. Wall squats are good, working on more functionally sitting to standing, all of that to get the quadriceps going. If they do present with that sway back posture, we can address the lower abdominals just because those commonly do come hand in hand. So that's another area that we can address. There are a lot of ways to do the lower abs. I didn't really get into it. And then we can stretch the gastrocs and the hamstrings because, like I said, the hamstrings tend to be pretty over-dominant in these patients. Okay, so the third diagnosis is tibiofemoral hypomobility, and there are kind of two different paths that this can present as. In both of them, you're just going to see that loss of range of motion at the knee. And it could either be due to immobilization, so more like surgical, or it could be due to degeneration. So that's typically patients over the age of 55. You'll see more of that degeneration. But any age could have that immobilization if they've had a recent surgery or trauma or anything like that. Their pain will typically be more deep inside of the joint, so that's kind of what they will complain about. And when you're looking at their alignment, you may see that they're standing in flexion. They're not getting full knee extension. Obviously, we don't want hyperextension, but we want to see that they can stand with full extension and not maintain a flexed position the whole time. And then their joint just may look inflamed or swollen or enlarged if it happens to be more of the degeneration side. So good tests for these patients, we want to look at their gait. We want to see if it's kind of antalgic or if they're putting more weight on one leg than the other. They might be kind of trying to protect that one side, especially if it's been immobilized. They might not be wanting to put that weight on the affected side. They might also have a shorter stride length just because they're not able to get that full knee extension. So they're kind of taking shorter steps because they're compensating. You can look at step down for these patients, going down a step. Because they're limited in both flexion and extension, they may not get enough of like the absorption when they step down, so that may be painful for them. They may just step down very rigid because they're just stiff in all directions. And then we can just look at range of motion, so put them in supine, see just if they have full range of motion, and that right there kind of tells us if they might be a hypomobile patient. So functionally, we want to give them some cues for gait. We want them to kind of use that softer landing on the heel. We want to increase getting that heel to toe, so they're walking instead of just getting foot flat every time. It takes some of the stress off the knee to get heel toe. And then we may have to resort to recommending an assistive device at this point if the patient is just in a lot of pain. The assistive device might just help offload their knee. And then we want to try to work away from this, but early on this may be a good option for the patient for gait. For sit to stand, we want them to work on scooting to the edge of the chair, getting their weight forward, taking some of that weight off their knee, and then trying not to let those knees push against the chair to stand, because for these patients, we want them to strengthen those muscles, and all patients, but we want to make sure they're not getting that assistance from the chair to stand up every time. For stairs, again, they can use that handrail to kind of help offload if they are having pain in the leg. So similar to an assistive device, if they need that handrail for offloading, you may want to suggest that early on. Additionally, this may be a patient that needs to use a step 2 pattern going up and down stairs just until they have more mobility in their knee. They may actually get more pain by going every other step. And then for a patient, especially the degenerative patients, we want to start doing some fitness things, high rep, low weight, because what we were told in school is if you start doing too much weight, the patient's muscles could actually tighten too much and just cause more compressive forces on the knee and in turn cause more pain for them. So we were told if you do high rep but low weight, it kind of lets them maintain the strength that they have but not strengthen too much to the point where it's just going to put more compressive force onto that joint. So things like stationary bike, elliptical, water walking, or swimming are all good ways that they can maintain fitness without putting too much compressive forces onto the joint. And for these patients, it is really good to educate, because if they're having a lot of degeneration and they might be like a more obese patient, this is just going to continue if they don't address that other side of things. So seeing if we can get them into a fitness routine or get them to lose a little bit of weight, because that'll take a lot of pressure off their knee. So just something we might want to educate on. And then when you're giving home exercises for these patients, if they are immobilized, we're okay with a little bit of pain if they're doing their exercises, because we're trying to get that range back for them. But if it's a patient that has degeneration, we kind of don't want that pain or pressure. That's kind of a sign for them to stop with those exercises. So just little differences between the two different tibiofemoral hypomobility patients. So key exercises. We do have a lot of strengthening we want to do with them. We want to strengthen the glute med and the lateral rotators. Again, we can do clamshells, prone foot pushes, lunges. We want to strengthen the glute max, prone hip extension with knee flexed. We want to get the gastroc stronger, so we could do standing heel raises for that. Then we want to stretch hip flexors, gastroc, and hamstring. So a lot, especially the more degeneration patients, might have that forward flex posture and those knees are flexed. So stretching the stretching the hip flexors might give them a little more mobility overall. And then we can use mobilizations for these patients, so joint distraction, like that bottom right picture that you guys are seeing, or even just working on range of motion is going to be key with these patients. You can use bracing. I have not done it, but they said that an unloader brace is something that could be used with these patients if nothing else seems to work and that degeneration is just too painful. So the next diagnosis, patellar lateral glide, this usually is more of a secondary diagnosis, but it is commonly seen. So that's why it's still early on in the diagnoses. And it's basically when a patient has that poor patellar tracking, so they're getting pain because probably their primary movement diagnosis causes them to get some lateral tracking of the patella, and then they're having additional pain due to that. So their primary diagnosis may not fix all of the pain. You might have to then address this lateral glide. And this can be pain behind the patella or just around the patella. Typically, it's patients that are doing a lot of loading in a flex position. So maybe they're running up and down hills or doing a lot of squatting with large loads. So that sustained knee flexion. And what you'll see is that patella sits a little bit laterally on the femur and the tibia for these patients. So not a ton of key tests for this one, but the big things I would look at is either squatting or stepping down, putting that load in that flex position, and they'll likely have pain unless you kind of manually position the patella so it tracks better. That will tend to decrease their pain. Prone knee flexion, again, it may be tracking poorly when you get that knee flex, but if you manually give that medial glide to the patella, they'll have decreased symptoms, less pain. And then if you look at them in sitting, when they're extending the knee, you may see poor tracking of the patella as well in that position. So functionally, these patients might be people that are in too much flexion. So they're actually in prolonged periods with more than 90 degrees of flexion. So this picture I found is supposed to be a very ergonomic chair, but if a patient did have patellar lateral glide, this would actually be a really bad position for them to sit in for prolonged periods of time, because they're putting a lot of force on the knees as they're bent in way more than 90 degrees. So if a patient can't avoid being in a flex position for all day, if they're have a desk job and that's their position, you can just have them get up more often. So we don't want them staying in that position for too long. And then you'll want to treat to the primary diagnosis if you give this as a secondary. So good exercises, we want to strengthen the VMO, so quadriceps in general, but we want to get that medial side of the quadricep working a little bit better so that maybe our patella can be aligned a little more properly. So we could do more functional things, step-ups, sit-to-stands, squats, lunges, all of those are good, just making sure they're in good alignment so we are getting the VMO to work a little bit more and to get a little bit stronger. We want to stretch the TFL and the ITB. So again, that prone position where you're flexing the knee, trying to get them into more adduction puts more of a stretch on the TFL. And then we can do some taping or some mobilizations. So we could do medial mobilizations if they are too lateral, and then taping, there's the McConnell tape, and that puts them in a medial glide, and you can use that to assess if the lateral glide is what's causing some of their pain. So you can try taping them one day. If that seems to help, use that to help guide your treatment, because they're probably a patellar lateral glide diagnosis. Okay, so knee extension is the next diagnosis, and it's different from hyperextension because you're not going to see them locked back just hanging out on that joint. What you're going to see is a very over-dominant quadricep muscle, and it can be associated with superior glide. So sometimes it's not, but they may have, because their quad is so dominant, it may actually pull the patella up and cause them pain. So that is usually seen above the patella, or it can be below the patella, depending on how much stress they're getting on those tendons. Typically, this is athletes like runners, football players, volleyball, people that are doing a lot of knee extension, but not hyperextension. Again, I said you'd see that overactive quad, and then these patients may also have that sway back posterior pelvic tilt combination. So the key test for a patient with the knee extension is if you look at them doing a step up, they will have more pain because they're not really getting their weight shifted forward. They're kind of hanging back, and their quad is pulling them forward. So you want them to try to get more anterior movement so the quad doesn't have to do all the work and stay as dominant as it is. You can also look at them jumping. They'll probably not get enough flexion, so whether that's from the start to the end, they're not letting their body kind of go into that flexion, and the quads are just tightening up and controlling. Okay, so functionally, a big part of these patients is we want to get that anterior weight shift with things so their glutes can work harder and take some of the stress off of what their quads have to do. So with walking, weight shift forward, we want to get that heel to toe like with many of the other diagnoses. If they're going from sit to stand, get them close to the edge of the chair, bring their body forward as they stand so they can really use the glutes, and you're not trying to sit up with just your quads doing all of the work. With sitting, again, we want to avoid that flexion over 90 degrees with these patients. For stairs, get that weight shifted forward as they're going and as they're ascending the stairs. And then I put running in here. Running, we can really do that for any of the patients, get them back to running. But I think since a lot of runners do present with this dominant quadricep knee extension diagnosis, that's why I put it there. So we can start with getting them back to walking, look at the mechanics with walking, then do some walking and running, and then ultimately get them back to running without overusing the quads. For these people, obviously, we want to avoid a quad-focused strength program because they already are too dominant. And if we're having them use the bike in the clinic, like to warm up or anything, these are the patients we want to say push instead of like pulling your legs up, pushing to get those glutes firing a little bit better as they're pushing on the bike. Okay, so good exercises for these patients. We want to stretch the quads, we want to strengthen the glute med, and the glute max is what I put here, but also the glute med. And then we can do some taping and mobilizations. So stretching, you can put them in the hip flexor length test position, and the focus would be on bending that knee in. You'll get a nice quad stretch with that. You can also put them in prone and work on flexion, trying to get the quad stretch that way. For the glutes, you can do lunges, squats. It can be more functional, or you could do that prone hip extension, knee flexion position as well. Taping, you would want to tape for the superior glide, so either horseshoe taping or show pat strap. I don't really do a lot of taping, but those are options. And then you can inferiorly glide the patella to try to get it to sit in a more inferior position if they do present with that patella alta and that superior patella. So the last MSI diagnosis is tibiofemoral accessory hypermobility. So this is a patient who doesn't really fall into any other category based on their movement impairments. They might just say, I feel like my knee is giving out, or I feel like I have a lot of instability in my knee. So there may not be a movement that goes along with it specifically. So they may or may not even have pain. Again, it might just be that instability component. This could be athletes that have to do forceful deceleration, so that's runners, field hockey, soccer, all of those. And then, like I said, alignment, maybe not anything specific with alignment, but just with movement, you'll see instability. So key tests for this, you do want to test those ligaments. So ACL, PCL, you could do MCL, LCL. And then for movements, you want to look at things like the step down, single leg hopping. As they're landing or wading through that leg, it will just look unstable. They'll have poor control of the knee and of the patella. And then functionally, again, that instability will be noted. So we want to do a lot of strengthening for these patients because if they are truly unstable, we need to get those muscles working better for them. So I've talked about specific exercises, so I'll just run through. You want the glute max, the glute med, the lateral rotators, quads. We can even look at some balance for these patients because if we can get their balance more under control, they'll have more control of their muscles and it'll improve their proprioception. And then we could brace if we really need to, so a derotational brace would give these patients some more support. Okay, so if a patient doesn't fall into any of those movement diagnoses, like they recently had a surgery, maybe they're not even weight bearing yet, or they had a traumatic trauma happen to them, then we can give them a tissue impairment diagnosis. So there are 3 different tissue impairment diagnoses that are given. We'll get into that on the next slide. So likely these patients will be standing in an alignment where they have a protective stance or they're weight bearing on the leg that's not affected because they're having a lot of pain or problems with the affected leg. So the overall goal when you're giving a tissue impairment is we want to get that range back if they are limited on that, and we want to strengthen without putting too much stress on the tissue that we're going to re-injure it. So that's our goal. Stage 1 is usually given if it's a patient that is very acute after post-op. So we had a patient that recently had an ACL surgery and wasn't even bearing weight on his leg yet. So that's a patient you can't do any of these MSI tests with, so you wouldn't be able to give an MSI diagnosis. So your goal in this stage is you want to protect the tissues. We can do a little bit of range, things like that, but we want to decrease inflammation overall. Stage 2, you can do a little bit more. At this point, you might have an underlying MSI diagnosis. Again, you can't do all the tests with them to fully make your decision on what diagnosis to give them, but you might be having that underlying idea. So we can kind of do a little bit more, progress some of those exercises, start putting more stress on them, but still be careful. We want to avoid that re-injury. And then stage 3, I never really give stage 3 because at that point I'll just give an MSI diagnosis to the patient. We're doing higher level things, we can get them back to their normal activities. So stage 3 isn't something I would ever really write on the paper. It would more just be that movement system diagnosis. So in summary, I kind of did a little case study on a patient I saw the first or second week just to put together what I would think through when I'm seeing a patient and how I would get to my movement system diagnosis. So it was a 57-year-old woman. She had right knee pain for about 6 months because 6 months ago she had a motorcycle fall on her leg. So she had some pressure on that knee for about 1 to 2 minutes and it was just sustained. And since then she had been having knee pain with bending the knee, squatting, kneeling, getting up from standing. All of those were causing her problems. She had pain in the morning once she woke up, but didn't have any pain that woke her up during the night. Her pain kind of fluctuated from 0 to 10 to 5 out of 10, so it was intermittent, just with some of those activities that I mentioned is what increased the pain. A little bit about her, she was a retired teacher. She liked going on walks. She did Zumba for fitness, and I gave her the LEFS. She got a 60% on it upon initial evaluation. So her posture presented with that sway back. Both femurs were medially rotated and hyperextended. She had some adduction of the knees, so maybe some valgus with that. And then her right patella was positioned a little bit laterally. So that's what she looked like. This is not her, but this is a picture kind of similar to her. So based on all that, I gave her the working diagnosis of tibiofemoral rotation with underlying knee hyperextension. And I used what I found in the alignment as well as what I found in her single leg stance and her gait. So in both of those, when she was standing on the right leg, she got more of that medial rotation of the femur, and she also got more of that knee hyperextension. So those were the big things that stood out to me, which is how I got my working diagnosis, my movement system diagnosis. So tibiofemoral rotation with that underlying knee hyperextension. And some of the other tests I did to come to that conclusion were I put her in the modified Ober position and just found that the TFLs actually on both sides were short and stiff. So that goes with that medial rotation of the femurs. Her glute med, she was unable to hold the position even, so very weak hip muscles. With a forward bend, she was actually flexing her knees in order to avoid that knee hyperextension that she was presenting with. And I think she was using that as a way to compensate for her short and stiff hamstrings, because I think she would have much more limited range if she didn't bend the knees while forward flexing. I said what I saw with gait, that medial femoral rotation, and then hyperextension of the knee. And then I looked at a partial squat, and I said that she got more anterior movement of the knees, so that puts more pressure on the knees. She's not using the glutes or the hip muscles as much. And then I didn't put it on here, but she also had that adduction pattern that she presented with in standing. So that just again tells me some weakness of the hip muscles. So I determined that the major contributing factors to her pain were the short and stiff TFLs, the weak glute medius, the hamstrings were probably short and stiff, overused, and then the movement impairments that she presented with. I wanted to address some of those mechanics to see if we could decrease that pain. So the exercises that I came up with were first wanting to strengthen the glute med. We talked a little bit about how to do so. Strengthen the glute max as well due to that knee hyperextension a little bit. Stretching the TFL. And then I didn't put hamstrings on here since I put knee hyperextension as her secondary diagnosis. I was mainly addressing the primary diagnosis I gave her, but I would definitely want to address those hamstrings. And then I wanted to look at the mechanics of her functional activities. So gait, sit to stand, step up, squat, all of those things. And then we addressing the bending down and the kneeling that she was complaining of, because likely I would see those same movement impairments of the femurs medially rotating and some hyperextension with some of those. So trying to address all the things she does in her daily life as well as the things that cause her pain in order to see if we can get her pain-free. That's everything you need to know. Yay. Thank you, guys.